Hi, folks. My name is Dean Sprage. I'm CEO of Medical Fitness Solutions, and today's session is going to be concerning long COVID and the complications as a function of this prevalent disease. We'll cover in the agenda today the definitions. Some of these are moving targets, studies. There's a plethora. The genesis, the extent, how long it's lasting, the common manifestations, and there are many, and then baselining, reporting, and then interventions. What are we doing to address these issues with our residents, clients, patients? So the definition of long COVID, the agreed upon definition is post-acute. Any manifestation is lasting over a month post-acute COVID. And 24 million people have identified or been diagnosed with long COVID in the United States. 80% have presented with issues that affect their work or their personal life. And we have 4 million people out of work. So it's a big issue. Out of the almost 5 million studies, memory impairments, neurological issues seem to be the most prevalent, the most pernicious. Seizures, mental health issues, depression, anxiety, tremors, movement disorders, balance, all the above have been reported as issues from the long-term manifestations of post-acute COVID. And to give you a little idea on what we think the genesis might be, what this autoimmune and inflammatory issue is within basically all the systems. We're talking about neurological, we're talking about cardiopulmonary, we're talking about musculoskeletal. So this autoimmune response and this inflammation, we believe, is a big part of the challenges we're seeing with long COVID. And this is Dr. Philip McMillan. And Dr. McMillan is a researcher and an MD with a group, the World Medical Health Group. And this is a good overview, on autoimmune response and the inflammatory nature as a function of the protein spike being attacked by the T cells and the immune cells in the system, and also the microglia in the brain. There's not going to be a test on this, by the way, afterwards. It's just to give you an idea of what we believe is causing some of these neurological, physiological, as I mentioned before, cardiopulmonary challenges. And it may provide an explanation as well for the blood clotting, and what we'll talk about a little later on in the session as well is some of the complications from that, including ST elevated myocardial infarctions. So this gives us a pretty good idea of what we're facing potentially throughout the system. And at first we thought it was affecting mostly older women, and it made sense. Women outlive men. A lot of these manifestations are exhibited and presented primarily in older populations. But then more recently, and this is as of last month, we're seeing that the diagnosis and complaints being issued are more likely in the 30 to 59-year-old group. Still balanced toward women, slighted toward the women gender. However, you look at the 30 to 59-year-old and you think, well, why in that age group are the major complaints, the highest percentage of complaints? And then you look at 80 years and above, and a lot of people with whom we work in residential and rehabilitation. Well, one of the hypotheses that actually I have is that maybe these people don't notice nuancal changes in cognition and balance, as opposed to some people who are, let's call it working age, that have to think through things, that are professionals, that are making decisions, that are more cognizant of their balance, and are probably on less pharmacological interventions as well. So I think it's being felt because of the prevalence of acute COVID throughout the population in those working age 30 to 59-year-olds at a higher percentage. Not to discount what's happening in our arena, because we know that is prevalent. And one of the other challenges is that it's long lasting. So I'll share with you a case study a little later on, but we're getting diagnoses 2 years into the virus, and lots of them. So this is a meta-analysis of several 100,000 people, and they're still having issues or being diagnosed 2 years after the acute stage. Dr. Goldstein puts it kind of tongue-in-cheek, succinctly. We really don't know. It's a new virus and a new post-acute virus challenge. So his opinion on that long COVID is basically, we don't know. So with the studies and with the vaccines and with the post-acute and with the diagnostic criteria that's used now, is, he mentions, now that we have long COVID figured out, are there any questions? A lot of questions. We're going to hopefully answer some of those today, or at least be able to provide you with some tools to work with these patients and residents and clients who are exhibiting these issues. Cognition is number one. So the brain fog seems to be the most pernicious and the most presented with these individuals. And it's somewhat analogous to a post-surgical delirium, but post-surgical delirium is transient. And we don't know how transient this brain fog malady is. Some people have presented with it for months, probably will be years as we go forward here. But it's the most prevalent complaint we have is the cognitive brain fog. Also, muscular weakness, difficulty in activities of daily living, and with our population, it's more concerning than the younger folks, because we start with a sarcopenic or an osteoporotic, more frail population to begin with, and then post-acute disease and post-acute lockdown, we're dealing with more frailty than prior to the COVID. And then psychological, and I don't want to underestimate the the impact of psychological as well. You look at seizures and you look at mental health issues, almost half the people exhibiting long COVID, one of their complaints is depression and anxiety. And it could be a function of lingering disease. It could be a function of lockdowns. It could be a function of lost loved ones, but it's real. And then the adjective they use here is startling. And that's probably appropriate because you look at no culprit lesion, so no indication that these people are going to experience an ST elevated myocardial infarction. And so 10 times as many women and 3 times as many men have now presented with a myocardial infarction post-acute COVID than would be indicated by the diagnosis and any culprit lesion. So we're going to tie that back to blood clots. We're going to come around and address that as well in some of our interventions. Chronic fatigue. So we're looking at symptoms similar to chronic fatigue or chronic fatigue. I'll throw in migraines as well. But it complicates things. We start looking at some of the interventions that make sense when we start breaking down the genesis of these issues, and then what are we going to do to address those going forward. But we've got over 200 symptoms associated with long COVID. And a lot of them might be psychological, but many of them, and the ones we've outlined here, are the most prevalent. Now, if we leave these folks alone, and again, especially in our population, there's not a lot of good outcomes. So, the musculoskeletal thing is one thing, but also decision-making, driving, paying bills, things that some older people struggle with to begin with can be exacerbated with the long COVID. Now, the traditional path, because this is new, it's new disease, new manifestations post-acute. So this is UCSD, prestigious facility in Southern California. And basically what they're doing is referral specialist. And I've got case studies that I'll share with you too, at least one in particular, that went through the route. And it likely has to be done because some of these manifestations may be indicative of a brain tumor or blood clots or a potential stroke or whatever, sleep apnea. So it needs to be ruled out, but it's slow and expensive. So what we need to do, look at the 24 million people again, and that's growing, that number. We can't all be bottlenecked at the acute care and specialists tier here. Once the diagnosis is made and ruled out that these are not life-threatening, immediately life-threatening issues, then we need to shift down a tier and then eventually shift down another tier, because otherwise we're not going to be able to scale the treatment and be able to treat all the folks that may be affected by these lingering aspects of post-COVID. So what we're looking for is a quicker, accurate diagnosis. We've got some ideas on that we can share, but we will get bottlenecked if all these folks are having these issues and start getting bounced around specialist to specialist. Hopefully there's something we can do at the GP level or neurology level. So given all that background, the goals for our interventions were, and based upon the manifestations, is we wanted to get clients to irisin lactate level of exercise with engagement, and I'll go over that in a little more detail. And so those are the things that we want to do to get them to create more brain-derived neurotrophic factors and neuroplasticity, and reduce blood viscosity. So those are all exercise-oriented. And then we want to look at nutrition. We want to look at blood donation. We want to look at, again, the blood viscosity is going to come up several times in this discussion. With physicians' approval, aspirin, coffee, and tea are vasodilators. And then we want to measure these interventions and tweak relative to the efficacy. You're going to hear me say several things repeatedly in this session. One is anecdotal, one is observational, and another is BDNFs, and that's brain-derived neurotrophic factors. And the neat thing to convey to you folks and for you to convey vicariously is you control your BDNFs. And you control your BDNFs by exercise and nutrition and stress reduction. And so you've got the control over some of these interventions, these non-pharma interventions in your own being. And we really started with the premise because we do work with people with Parkinson's. We actually have a scholarship program from North County Parkinson's Support Group that will pay the first month for Parkinson's patients to come visit us, where we can do a workup and analysis and start them with an exercise intervention. And the manifestations of long COVID, some of them are very similar. We're looking at some brain fog or cognitive decline. We're looking at balance issues. We're looking at tremors. We're looking at depression, anxiety. We're looking at weakness. We're looking at drugs. So starting with that premise, and then the monkey wrench is blood viscosity, because we're seeing increases in blood viscosity post-acute COVID. And I'll bring this up now. I'll probably bring it up again later. There's fairly simple tests for blood viscosity. And and I'm not smart enough to know this, but if there's a criterion by which a physician can look at blood viscosity and maybe rule out some of these other more dangerous things to get a quicker diagnosis, we can intervene much quicker with these patients. But the blood viscosity is the issue that differentiates these interventions from others with clients with whom we work. So what we do is on an intake, we get as much information as we can. We have a health questionnaire. We do body composition. We do balance assessment. We do cognitive assessment, strength test. And then based upon that, we will begin the individual at their appropriate level. And then we'll advance them in the program as they achieve the goals set forth for them. And then we increase the intensity, we increase the duration, we add other aspects of the interventions if the individual can tolerate. So we'll do a visual, vestibular, proprioceptive, and cognitive screening. We use a device that has a malleable platform that allows us to assess and get a numeric value and a visual value of how these clients are performing in balance. And then we get real granular with
the CogniView test battery
device that we have
psychophysics to measure patient thresholds through a series
and this
of
is the
key
de novo
domains,
FDA recognized device that scores cognition in 6
function,
different domains of the
perceptual
brain.
processing, and memory.
And this gives us a really good idea
name,
of how this individual,
gender,
from a baseline perspective,
as well as the test language,
performing.
and then selects
and I'll give you a little taste of that and how it
the
works.
Test by turning the cogwheel 360 degrees. The testing begins with the adaptive motor control test. This tests a patient's fine and gross motor ability and uses their thresholds to calibrate the rest of the test to their individual pace. The next test measures the patient's visual capacity. The remaining tests are calibrated to accommodate the patient's actual visual ability by adjusting the size and contrast of all subsequent tests. The next 4 tests measure perceptual processing through 4 different domains, including letters, words, shapes, and motion. The letter discrimination test requires the patient to find the real letter among non-letter symbols. The difficulty of the test increases when the patient moves to the correct answer and decreases if they do not. Each test begins with 3 instructional trials, which allows the patient to transition from test to test efficiently and effectively. The word discrimination test measures the patient's ability to find the real word among non-words. As the difficulty increases, the amount of degradation added to the stimuli increases.
Okay, so that
The
gives you a pretty good
discrimination test
idea.
measures the patient.
It's a 10-minute test,
The-
and it's self-administered. So it's low labor component associated, but we can get really granular on 6 different levels of assessment. So visual, spatial, executive function, naming language, memory, delayed recall. And then within those, abstraction, within those we get scores as well. So this gives us really good information between the balance and the cognitive. Let me go back one here. On how the patient is performing from an acuity and a cognitive perspective. Then we do a strength assessment and we do a body composition analysis. So with that body composition analysis, we get muscle mass, we get fat, we get basal metabolic rates, we get hydration levels. And many times we're working with people that'll have a great BMI, but they're sarcopenic. So we see more frailty than anything else. Most of the time we're trying to put on or keep muscle mass. And we do that, and I'll explain that how we work with our clients from a anabolic eliciting perspective. So we get this good baseline information on the individuals, and then we start the interventions. And I'm going to go over what we do in our facility, but you probably have other modalities and other methods. And I think once we share the ideas of what we're trying to do, a light bulb will go on in your head and say, oh, I can do this in my facility, or I can do this in my facility. So the options are in your handout package, and you may have some that are not addressed. But, instead of the cognitive view, you may have another way of, let's say it's the Alzheimer's disease assessment scale that you use, or the slums, or something like that to baseline these individuals so we can, again, measure the efficacy of these interventions. Strength training. And strength training is across the board in dealing with older people is the cornerstone from my perspective on healthy living. And it's relatively, it seems mundane, but the way we do it, we've had good success. We've had over 3 million resident patient treatments, 0 reported injuries, proven cost of care reductions. And we use something, a method that is fairly simple,
set,
but it's
go.
slow,
1,
controlled
2, 3,
movement
pause.
where we try to keep
1,
tension on the muscle,
2, 3, 4,
enough tension on the muscle to
5,
occlude the muscle from
1,
getting oxygenated blood.
2, 3,
So we want to
pause.
bring individuals
1,
to the lactate level.
2,
And I explain to
3,
people, we don't want
4,
orthopedic pain.
5,
We
1,
want lactate burn.
3, pause.
Because if we get there, if we
1,
can bring a
2,
patient as close as we
3,
can to failure
4,
on a particular exercise,
1,
we know
2,
we're going to elicit an
3,
anabolic response.
pause.
We know we're going to
1,
create sarcoplasmic
2,
hypertrophy.
3,
We know we're going to increase capillary
5,
density.
1,
We're going to get a bevy
2,
of benefits
3,
um, from
1,
this type of exercise.
2,
And without
3,
the ballistics
4,
and supporting the patient
5,
fully
1,
and with the proper
2,
biomechanics,
3,
we're going to get the
pause.
best outcomes
1,
with these
begin
individuals in our
exercise.
strength training program. A bunch of birds with one stone, because we're going to get better cognition. If you look at this study, big study, almost twice as good of outcomes with individuals who are doing the strength program in that Alzheimer's disease assessment versus the ones that weren't. So in addition to, lower blood pressure, better lipid profiles, more strength, better ADLs, better sleep, better mood, you're also getting better cognition. So strength training, cornerstone. And then engagement exercise versus distraction exercise. So we know, really good study done by the Cybercycle company that showed a 23% reduction in the onset of dementias and Alzheimer versus using engagement exercise versus distraction exercise. And engagement exercise is when you're elevated heart rate, oxygenated blood to the brain, making decisions. So we use the Cybercycle in our facility where you're steering, you're shifting gears, you're racing with other people, you've got elevated heart rate. And then we also use it, there's a few other modalities we use, and the core balance is one of them, and I'll show you the neuro tracker. But we also use a fight master. So this is actually Dr. Tom Ronan in our facility, and he is a physician, retired physician in Scottsdale, and went through the program with us. He works with individuals in the Muhammad Ali Center in Phoenix, and he and I met and discussed the programming, and he's actually had Parkinson's for 10 years, and he got involved in this engagement exercise on his own, and decided it worked, and is a proponent of it for patients as well. And then we ramp it up even more when we talk about multitasking. We use something called a neuro tracker. So we'll get an individual on our core balance device, and then we have a series of targets that are highlighted, and then the highlight goes away, and you have to catch those in your peripheral vision as they're going in different directions while you're keeping your balance on this device. So now you've got visual, vestibular, proprioceptive, peripheral vision, reaction time, all on the same device. And here's a little example of 81-year-old gentleman, retired fire chief, doing the multitasking 3D challenge here in our facility.
Okay, now challenge yourself a little more. Try to let go at least with one hand on the balance, not speed. See, you did too well, not speeding up on you. Now you're going to be guessing again. Now keep an eye on these four. As much as you can, try to work on your balance. Oh, you're going to multitask here. Okay, here we go, 8 seconds. Bueno.
Okay, and then we look at progressive balance training. What I mean by that is we have different rigidities on surfaces that require more metabolic demand or ankle strategy or center of gravity control. And we have those on a modality with a biofeedback loop. So now we got visual, vestibular, proprioceptive responses and adaptive training on those devices. And then subconscious proprioceptive response. So we work with a modality that goes up and down, back and forth, and side to side. It's a mechanical instability device. And that creates repeated action potentials in the muscles without going through the CNS. You fire muscles whether you like it or not. And so that increases proprioceptive response. It does several things. So subconscious proprioceptive response gets better. It's a mechanoreceptor block of pain with the repeated action potentials. It overcomes Golgi tendon response. And when we're working with stretching, it increases HGH, reduces cortisol. And so we work on both the subconscious and conscious. And with that type of device, a really good study, 710 women, I think the average age was 70. I think it was a 6-month program, 40% reduction in falls and a 50% reduction in fractures, really attributed to the subconscious proprioceptive response on that modality. So we've been talking about exercise and lactate, and the reason we continue to go in that direction is there's good science, and I'm not smart enough for the background of it, but I can share a graph that depicts what happens. But in getting to lactate and irisin level, which is one of the newer research hormone, you're able to get the lactate to cross the brain-blood barrier, which creates an increase in brain-derived neurotrophic factors and neuroplasticity. But it happens when you get the lactate. And lactate we've always thought of as kind of a byproduct or a waste product of exercise. It actually is a facilitator of acuity and neuroplasticity. So that's one of the reasons we're going to talk about more about getting to lactate level in these exercise interventions. And then all exercise interventions, we talked about earlier is depression and anxiety. Well, all exercise interventions, a lot of good science on endogenous opiates and feeling better and self-esteem, et cetera, with folks who are exercising. So multiple birds with the exercise stone. But, I don't leave it there. Recently, I took a couple-day course on mental health first aid. So I'm not a psychologist, but it helps me identify individuals who may need help that I can't give them, and referral sources for the mental health aspect of it as well. So we can work on BDNFs and mood and exercise and trying to clear some of the brain fog through adaptation, neurological adaptation. But there may be some underlying issues that certainly we can't address, and maybe some of you in the crowd, but not us. And then other things we can do is, donating blood. Blood viscosity is reduced by donating blood. That could probably help in the blood clotting arena. If your doc allows you to take baby aspirin, that might be a solution. Caffeine, vasodilator. A lot of good studies on caffeine, thank goodness. But also saunas, and I've got one more slide I'll share with you on that in the research that came across my dashboard. And then supplementations. And then, of course, strength training, cardio exercise to the lactate level. Now, saunas. So my wife and I have a sauna at home, and I'm doing research for this. So I started thinking, we took a sauna, and your vascularity is more pronounced. You're at 200 degrees. You're trying to keep your body cooler. You're sweating profusely. Your heart rate goes up. But you're passive. And let's go back to, let's say, some of the issues that maybe pulmonary inflammation or maybe chronic fatigue may not allow you to do some of these aggressive exercises, but you're getting vasodilation and elevated heart rate passively in the sauna. And then a really good study out of Finland, 22% less likely to get dementia 2 to 3 times a week. And then if you're using it, let's see here, 4 to 7 times a week, 66% less likely to get dementia than those who use the sauna once a week. So why is that? It's likely oxygenated blood to the brain, vasodilation, increased endogenous opiates, all the above, but the outcomes are pretty incredible. Then nutrition. A lot of facilities that cater to older people have really good nutritionalists and chefs and people, food service, but some don't. And so as much as you can mentor the individuals you're working with on eating well, it's a huge part of it. And what we do is, we work with a lot of folks with loss of muscle mass. And so some of the things that we're doing they're supposed to create an anabolic response when we get to that lactate level. But if we don't have a sound nutritional foundation, it could be a catabolic response. That's not what we want. So we work with a company called MEND, Targeted Medical Nutrition, primarily in the orthopedic space right now, some in the physical therapy space. But it's got, protein and HMB and creatine and branched chain amino acids, important for our older people, prebiotics and probiotics. So one scoop, they can put it in almond milk or regular milk, and we know we're getting a good foundation. We talked about stress and sleep, and this is something, again, my wife and I found and think works pretty well. It's this tea that has melatonin, L-theanine, magnesium, and GABA, I believe, and it works pretty well. And so getting sleep, getting restful sleep, lowering your stress is important. And then what's good for your heart is good for your brain, and what's good for your brain is good for your heart. Makes too much sense from a broad brush perspective that these things work. This is a case study I've mentioned a few times. This is Paul Leahy. He's a practicing attorney. He was referred to us by a medical group here. I'll give you a little of his testimonial.
All right, so Mr. Leahy, what brought you to our Lifespan Health facility?
My doctor recommended me here, and I liked what I heard, especially about the blood viscosity, because I had long COVID, or I've had long COVID. By that time, going on 13 months with migraine headaches and the like. So it sounded like something that could really help me. It was interesting. Since there's no answers to this long COVID dilemma that we have.
All right, and what goals have you achieved since being here?
I think I've got more cognitively matching with my body up. I've lost weight. I feel a lot better. I feel like I've actually got my life back a bit. I had some new medication with that and this. It's really made me feel a lot more empowered to be able to continue on when I was sort of hopeless before.
All right, and what goals still remain for you?
Losing more weight, becoming more strength, upper body strength, and just endurance, and just get better health.
All right, and what can you tell folks about the program?
Program is real good. They keep you on it. They work you hard. Don't slack on you. Push you. Reed's a good pusher. He keeps the record. Keeps your heart rate going, and it's just overall I recommend it highly. That's about what I can say. Oh, go Padres.
So many times I'm asked by individuals, and I'll give you an anecdote here. How long do I have to participate in a certain program? And the anecdote is 35 years ago or so, I hurt my back pretty bad. I got an MRI. There was some damage done. I went to the orthopedic surgeon. They said they can fix that. But an athletic trainer buddy of mine said, let me work on you for a little bit first. Probably 6-7 sessions. He was osteopathically trained and felt like a new man. And then when he discharged me, he gave me this little pamphlet, 12-page pamphlet of stretches. I said, okay, great. How long do I have to do this? Rest of your life. And if you want to stay healthy, if you want to keep your immune system, if you want to enjoy ADLs, you want to pick up your great-grandchildren, you got to do these things the rest of your life, over and above the long COVID duration. And then pragmatism. If you're a caregiver who's PTOT, speech, respiratory therapist, there are CPT and RBS codes that are applicable based upon medical necessity. However, we've designed technician level certifications as well, because at some point these patients have to become clients in order to do this affordably the rest of your life. And then I want to thank Graybill Medical Group, Dr. Frank Winton, who's the head of that here in Southern California. They've got 9 physician offices, and they've given us some patients to work with. They refer osteoporotic patients, they refer patients with Parkinson's, but also some for the long COVID study. Donna Diedrich, many of you may know here, VP of Clinical Ops at Aegis Therapies. She sat through the presentation and critiqued. And then Dr. Thomas Ronan, who you saw hitting the bags. And then Dr. Joseph Moore did what's called the murder board. I went over this with me, made sure we weren't making any misstatements, as did Dr. Franny Perez, who's an MD, ND. And here's a little tour of our facility. Give you an idea of what we do here in
Welcome to
Fallbrook.
Lifespan Health in Fallbrook, California. We offer evidence-based adaptive solutions for many of the challenges of aging, including loss of muscle mass, decreased bone density, balance and pain issues, diabetes, Parkinson's disease, peripheral neuropathies, mental decline, and nutritional deficiency. We utilize many FDA-recognized patented modalities to achieve optimum outcomes with minimum chance of injury. And we document your individual start points and progression with medical-grade body composition, patented cognition and balance assessments, and computerized strength testing. For our clients' protection, we covalently bond our equipment with an EPA-certified antimicrobial and clean with an unlisted, proven-to-kill COVID virus cleanser. And you don't have to be elderly to partake in these proven health maintenance solutions. An ounce of prevention is worth a pound of cure, so we recommend getting an early start to living your best life. Please contact us via the website or call 760-451-9162 to find out more. We hope to hear from you soon.
So that gives you a little idea on our facility. If you want to discuss further, here's my contact information. Happy to share and see what you're doing. And then this is how you get your CEUs. Self-explanatory there. I'll be hanging out here for a few minutes until they kick us out of the room if you have any personal questions for you. But other than that, thank you for your time. And I hope it's been hopeful to you and vicariously to your clients, patients, residents. Thanks so much.